Hello, everyone. So as Tracy mentioned, my name is Laura. I have Andrea Thomson here with me. She's our fearless leader for this project, and Jennifer Adair. And today we're going to be sharing on a scoping review that was recently done, focusing on workplace accommodations for nurses and midwives who experience disabilities. So we acknowledge that Brandon University has campuses on both Treaty 1 and Treaty 2 lands, those territories, and I am joining you from Treaty 2, which is the shared territory between the Dakota, Ayate, Anishinaabe, and the national homeland of the Red River Métis. And personally and professionally, I am committed to moving forward towards reconciliation through education, building relationships, and repairing harms and traumas of the past, as there are still many that exist today. So just so we're all on the same page about what we will be covering, we're going to get into the background information, the method, and share some of the findings with you. And then we will have some time at the end for discussion. So there is a global nursing and midwifery shortage. This has been declared, and it has led to an increased focus on recruitment and retention. One proposed strategy to address this issue centers on enhancing recruitment and retention initiatives for healthcare professionals who experience disabilities. However, there was a scoping review done by Baker et al. In 2023. They found that nurses with disabilities may leave the profession due to persistent symptoms, negative work environments, and a lack of workplace accommodations. There is legislation in place throughout most of the world to protect the rights of people with disabilities. An aspect of legislation requires that employers make reasonable accommodations to support continued employment of people with disabilities. In Canada, the duty to accommodate is identified in the Canadian Human Rights Act, and this legislation requires employers to adjust working conditions to promote inclusion of people with disabilities in the workplace. So workplace accommodations involve any change in the work environment or terms of employment that enables individuals with disabilities the opportunities to perform their job. And the purpose of an accommodation is to reduce or eliminate barriers for people with disabilities. Employees with accommodations must continue to demonstrate that they are qualified to perform the essential requirements of the job. So as you can imagine, misinformation regarding nurses with disabilities and workplace accommodations has been reported. First and foremost, there is a misconception that nurses who experience disabilities are at a higher risk for providing unsafe care and making errors compared to those who have not disclosed a disability. However, the research has found that nurses with disabilities have the potential to improve care, and they are more likely to act in an empathetic and compassionate manner, and are more often more aware of their strengths and their limitations. Another misconception is that accommodations are often viewed as a form of favoritism that places employees at an unfair advantage compared to their colleagues. This misconception can lead to a sense of mistrust from managers and colleagues towards those who receive accommodations. Are we going? Oh yeah, here we go. Sorry, I got lost on my notes. So the purpose of accommodations is to provide employees opportunities to complete the essential duties required of the job, rather than placing them at an unfair advantage. In addition, reasonable accommodations may not always align with the employee's preference and should not cause undue hardship on the employer, such as implementing shared positions or resulting in unreasonable financial burdens. So misconceptions and misinformation surrounding nurses with disabilities and accommodation practices contributes to the persistence of ableist attitudes in healthcare. A notable barrier for the recruitment and retention of nurses with disabilities includes experiences of stigma and discrimination from colleagues and supervisors. And one way to reduce ableism is to increase understanding. So that's why a scoping review was conducted to better understand workplace accommodation practices for nurses and midwives who experience disabilities.
Thanks, Laura. So as Laura said, we completed a scoping review, and the review looked at mapping existing literature available on this topic to identify gaps regarding workplace accommodations for nurses and midwives who experience disabilities. However, we were unable to locate any specific studies specific to midwifery. Therefore, this presentation focuses on the findings related to nursing practice. However, our population of inclusion was both nurses and midwives with disability, and we define disability as the interaction between individuals with temporary or permanent health conditions and personal environmental factors that can contribute, such as inaccessible structures and workplace environments, as well as attitudes. This is a fairly well-recognized definition coming from the World Health Organization. And we specifically looked at accommodations and assistive technology or assistive devices if those devices were provided as a form of accommodation. And we looked at all healthcare settings, and we included the definition of the study's healthcare setting. We wanted to specifically look at, what settings led to different types of accommodations. However, the majority of studies looked at multiple healthcare settings, so we weren't able to identify specific accommodations based on different types of practice settings. And we also excluded articles that were solely focused on alternative to discipline programs for nurses who experienced substance misuse, or studies that focus solely on gradual return to work programs. So we were quite fortunate to work with 2 librarians, and we initially did a pilot to review sample articles based on a preliminary search to help refine our inclusion criteria. Then a full search was conducted using CINAHL, Web of Science, Embase, PubMed, PsycInfo, ProQuest Dissertation, and SOCINdex. The search identified nearly 6,000 articles, which were then uploaded into Covidence, a literature review software, with over 1,400 duplicates removed. Our process was that 2 independent reviewers would screen all identified sources for titles and abstracts, followed by a full text review. Any disagreements that arose during any stage was resolved by a third-party reviewer. We also screened citations of the reference list of all included articles. And at the end of our scoping review, we identified 20 articles that met our eligibility criteria. So in terms of methods, of the 20 articles included, the publication dates ranged from 1998 to 2023, with most studies published between 2006 and 2015. 70% used a qualitative method, followed by mixed method for 3 studies, legal case reviews for 2, and quantitative studies was only identified 1 time. All included studies focused on nursing practice, as I previously said, no studies focused on midwifery. Nurses with disabilities comprise the most common sample group, with 55% on this specific topic. Managers and return to work coordinators made up an additional 4 studies, or 20%. Additionally, a couple studies included nurses with disabilities as well as managers. And another 2 encompassed a variety of populations, such as nurses with disabilities, colleagues, managers, occupational health professionals. And 1 study was from the perspective of nurse colleagues. As I previously stated, Over 60% of the studies looked at a variety of healthcare settings, such as hospital, long-term care, and community-based settings. So we're unable to describe specific accommodations based on practice setting. Most of the articles came from the United States, which you can see presented here with 60%. After that was Australia with 2, Canada with 2, France with 1, New Zealand with 1, South Africa with 1, and the United Kingdom also had 1. So at long last, here are the accommodations reported in the literature. I'm going to go through and talk about each different color code in more detail. So the first that was recorded the most was self-accommodations, which I'll describe. Then you can see in blue the accommodations that were reported to be provided, as well as in orange, assistive devices that were reported to be provided. And then the last 2 in green were accommodations noted to be unable to be provided by specific employers. So 50% of the articles included some type of description of what we termed self-accommodations. So this was the most common type of accommodation uncovered. Self-accommodation was described as an informal process where there was no written or verbal consent or formal process in place from employers to implement changes to their practice or environment. So nurses took it on themselves to make their own modifications. So examples of this involved learning to complete tasks new ways, modifying the environment, moving equipment, changing the structure at the bedside, and purchasing their own assistive devices. Often we found that accommodations began with that process of self-accommodating. However, ultimately, over time, it was burdensome to the nurse, and therefore, formal accommodations were often required for that nurse to continue to practice. So this slide depicts the formal accommodations noted in the included articles, as well as the assistive devices provided by the employer to nurses who experience disabilities. So the formal accommodations described in the studies was being reassigned to an alternative position, scheduling changes such as reducing hours, so reducing an EFT, or reducing the amount of night shifts that the nurse was working, or eliminating night shifts from the rotation, modifying their duties or adjusting a job description in order to complete tasks required. Creating ergonomic workstations. So commonly we saw sit, stand, desk reported or stationary chairs. Reduced lifting requirement was noted in 3 studies. Protected time to attend medical appointments was noted twice. Increased or regular breaks. So it could have been the option to take additional 15-minute breaks when needed. The ability to record reports. So at shift change, the ability to communicate through a recording rather than in person. And documenting in a private location was noted once as an accommodation. Travel restrictions was noted once, and so that one was specific to community-based settings. So, for example, the length of distance the nurse would drive to a setting, or the length of total time that the nurse would drive in their given shift. So, for example, maximum of 2 hours or a certain number of kilometers. And also no overtime hours was also recorded once. Then assistive devices provided by the employer to specific nurses as an accommodation included audiology devices such as amplified stethoscopes, amplified phones, microphones, vibrating beepers, and captioning. Visual devices included magnifying devices or larger computer monitors to assist with documentation. And in addition, specific devices to assist with lifting patients or moving healthcare equipment was noted twice. In addition, we noticed that there were some types of accommodations that employers were unwilling or unable to provide. So 4 studies found that a reduced lifting requirement was not possible. And this also included the inability of a nurse to complete cardiopulmonary resuscitation. So it was found that this would impinge on essential requirements of the job and therefore was deemed unreasonable in these studies based on our legislation. So just note a discrepancy here because 3 studies identified modified duties such as reduced lifting requirements, whereas studies here, additional studies deemed that it was not possible. So in this instance, we found it would have been helpful to perhaps identify specific healthcare settings and is this possible in community-based settings or not in long-term care? Unfortunately, we weren't able to map that particular data. In addition, modifications to environments to promote wheelchair accessibility for nurses with disabilities, such as increased space around a patient's bedside, were deemed not possible in 3 specific studies. We also found several barriers to accommodations. So nearly half of the studies reported unclear processes or pathways to request an accommodation as a specific barrier. So this was one of the reasons why nurses began that process of self-accommodating. They knew supports were required, but just weren't unsure how to access those particular types of supports. In addition, experiences of ableism or reluctance to engage in disclosure and limited availability of accommodations and resources were also highly reported. A small percentage of studies reported a lack of awareness on accommodations or the rights that they had. Managers were found to be both a facilitator and a barrier of accommodation access. In fact, half of the studies described supportive and collaborative managers as the main facilitator to accessing accommodations. Unfortunately, managers could also act as a barrier, as 30% of studies highlighted that unsupportive managers created challenges in accessing these types of supports. Despite the challenges noted, nurses with disabilities described enhanced nursing skills, including heightened awareness of safety, the ability to provide empathetic care. In these articles, we did not notice any reports of concerns about safety. Actually, studies involving the perspectives of nurse managers found that nurses with disabilities performance were often viewed as exceptional. And the more they worked with nurses who self-identified as experiencing disabilities, the more likely they reported that they were willing to hire them in the future. So just some additional details. As most of the studies were conducted against a variety of healthcare settings, it was difficult to analyze how setting affected the provision of workplace accommodations. However, in some instances, it was specifically described. And so I'll just talk about those specific instances, just more for your information. One study found that community-based mental health accommodations or accommodations in mental health settings were more likely to produce accommodations than that of acute care mental health settings. However, another community-based setting, this one specific to rural areas, found it difficult to accommodate due to travel requirements associated with the job. Conversely, compared to urban settings, rural locations were also reported to be more creative in providing accommodations in efforts to retain nurses. Of interest is the findings that one study had that the level of education of the nurse actually impacted the employer's ability to provide education. So nurses who were prepared with bachelor's degrees were more likely to be accommodated than those with diplomas or nursing assistants due to lifting requirements that commonly associated with those particular types of roles. And so there was greater ability to reassign those with a bachelor degree. Similarly, authors noted that accommodating nurses in casual positions or agency nurses were more difficult because they often work in multiple areas across different types of locations with different employers.
Thank you, Andrea. So, despite the challenges, nurses with disabilities noted enhanced nursing skills, including heightened awareness of patient safety and improved ability to provide empathetic care. Issues with unsafe nursing care were not reported in any included articles. A study involving the perspectives of nurse managers found that the performances of nurses with disabilities were viewed as exceptional, and that greater exposure to employing nurses with disabilities increased managers' willingness to hire them. While workplace accommodations were found to positively contribute to nursing care, the implementation was not without challenges. The need to self-accommodate was related to the barriers in accessing accommodations. Many nurses with disabilities modified tasks or environments without formal permissions and waited until they experienced performance issues to initiate the process of requesting those accommodations. The decision to delay disclosure was often related to unclear processes, as well as ableist attitudes regarding health professionals with disabilities, rather than a lack of awareness of disability-related legislation. This is problematic, as provisions of workplace accommodations had a positive impact on a nurse's ability to provide care and may serve to improve retention, whereas delaying accommodation requests can lead to increased rates of absenteeism. Light or modified duties were also noted as difficult to accommodate in nursing, given the complex care needs of patients and a lack of resources. Due to a strained healthcare system, nurses and midwives are often expected to work above and beyond their strengths and push their endurance. Therefore, positions that allow for light duties are likely in short supply. In addition, Neil Boylan in 2014 found that nurses are often required to complete tasks outside of their job description, making it difficult to offer accommodations. Despite modified duties being accommodated in a small number of studies, employers are not required to modify the essential requirements of a position. Reassignment, which was the most common accommodation noted, may cause conflict between managers, especially in areas with low staffing levels. In addition, reassignment may override a collective agreement, where a nurse with a disability is provided with a position over a nurse with more seniority. This may inadvertently reinforce false perspectives of favoritism and special treatment towards those accessing accommodations. The most common barrier uncovered centered on confusion regarding accommodations-related processes and policies. This barrier was identified by nurses with disabilities and nurse managers. Long waits, challenges with documentation requirements, unclear points of contact, and a lack of policy were reported. Workplace policies and processes that outline roles and responsibilities of employees and employers are instrumental in delivering successful provision of workplace accommodations. Transparent communication and a willingness to collaborate between the employer, employee, human resources, as well as occupational health is also vital. A streamlined approach would be cost-effective at reducing absenteeism and staff shortages. Existing policies should be revised to make disability disclosure and accommodation requests straightforward and safe for employees. A supportive manager was found to reduce workplace challenges for nurses. Unsupportive work environments contribute to experiences of burnout, job dissatisfaction, and the desire to leave nursing. Yet many managers were unaware or unprepared to support nurses with disabilities. Additional education on workplace accommodations in nursing and midwifery practice is required for employers, colleagues, and individuals with disabilities. Nurses and midwives need more education on their legislative right to access workplace accommodations. Given the barriers encountered, reliance on workplace accommodations to support nurses and midwives with disabilities is problematic. Accommodations are a reactive approach to meeting an individual's needs. And once that individual leaves the position, the accommodation is no longer in place to potentially support others. A proactive approach that promotes accessibility for all is required to decrease the need for individual accommodations. Examining the accommodations that are commonly required, as well as those that cannot be provided, offers insight into system barriers that should be universally addressed to improve access. Suggested changes to environment and access to technology that can be made available to all nurses and midwives include audiology devices on phones, large print with audio options, larger computer monitors, ergonomic workstations, recording devices, microphones, increased space in patient care areas, strategic placement of ramps rather than stairs, and readjusting difficult work schedules. These modifications will benefit nurses and midwives and can result in enhanced patient care. So thank you everyone for listening to our presentations. We will now be taking questions.